Today we have a girl who is 4.5 months old and she's a diagnosed case of galactosemia. She initially presented with jaundice. You can still see tinge of jaundice present in the eyes. If the camera can focus. She presented to us in the neonatal life with jaundice. On examination, she had hepatosplenomegaly. Still, the spleen is enlarged, as you can see the obvious abdominal distension. Still the liver is enlarged, and she also had an E. coli sepsis in the neonatal life. When we had this presentation of jaundice, hepatomegaly, splenomegaly, and E. coli sepsis, our first differential was galactosemia. We also thought about torch infection and sepsis as well. We investigated the child, and first of all we determined whether it is a direct hyperbilirubinemia or indirect hyperbilirubinemia. So the results came out to be direct hyperbilirubinemia. We also examined the eyes for oil drop cataract, because in galactosemia children have oil drop cataract. Luckily we did not have the cataract. We also did the torch titers, but they came out to be negative. She was diagnosed with galactosemia in neonatal life, and now she came on follow-up. And you can obviously see her faltering growth. This is the main concern we have on follow-up visits, that these children, they have faltering growth. They may develop proximal tubulopathy as well, and they may develop rickets as well. So I must look for the widening of the wrists. I must look for the frontal bossing. I must look for the rickety rosary, because these children can develop rickets. Frontal bossing is present, and so I would like to give vitamin D supplementation in this child as well. Now, you know about galactosemia and galactose in lactose, they're not being absorbed by the body, rather. So the treatment is to give a soya-based formula milk. We are currently giving soya-based formula milk to this child. And when you give soya-based formula, obviously these children, they get deficient in calcium. So calcium supplementation is also required in this child. After switching on galactose-free milk, the child has improved a lot. Initially she also had diarrhea as well, because obviously when glucose and galactose, they're not being absorbed in the body, they will lead to diarrhea as well. These patients develop coagulopathy, they can develop liver failure as well. RFTs are often deranged in these patients. So I have advised in ALT, and the ALT came out to be 144, as you can see in the report. You must know that in galactosemia there is deficiency of galactose 1-phosphate uridyl transferase enzyme, and due to deficiency of this enzyme, the lactose and the galactose, they are not being absorbed in the body. They are excreted in the urine as well as in the stool. So if you test the urine with reducing substances, the reducing substances in the urine will become positive. Later on, these patients present with faltering growth, proximal tubulopathy, and rickets at few months. They have a very strong association with E. coli. If you want to confirm the diagnosis, you have to do enzyme assays. Galactose 1-phosphate uridyl transferase enzyme assay. You have to confirm it. Once it is confirmed, you have to put patients on a milk which is soya-based milk. We do not have lactose and galactose. Soya-based formula, isomil, like other Nutramigen, there are other brands as well. Now, you need to call the patient on follow-up and look for the faltering growth, look for the proximal tubulopathy, and look for rickets as well. Keep an eye on liver function tests and coagulation profile. Supplement the patient with vitamin A, vitamin D, calcium, and make sure optimal growth of the patient. Keep an eye on HB as well, and once the patient crosses 5 months or 6 months of age, and when you start weaning, the weaning foods should also include lactose free diet. You can also consult a nutritionist for this purpose. Later on, these children may face complications, like in girls they may land into infertility. Most of the patients have a developmental delay. A patient may have speech delay, they may have feeding problems, and you can expect infections in this as well. Parents do complain of abdominal distension due to hepatosplenomegaly. Sometimes they develop pseudotumor cerebri. Sometimes they develop mental retardation. Sometimes these patients have hypergonadotrophic hypogonadism. Throughout the childhood, you need to keep an eye on these patients and call them on regular follow-ups and maintain the optimal growth of the patient and prevent the complications. And I hope that this video have helped you a lot in understanding what is galactosemia. See you in some other video with the series Teaching on Patients series. Please like and do share these videos and all those students who are interested in pediatrics. Thank you so much.